Hello, I am Dr. Jennifer Merez and joined today by my colleague, Dr. Rob Roswell, and we're here to have a conversation about the importance of the social determinants of health and why it is critical that we expand our healthcare delivery model to include the determinants of health to really ultimately impact cardiovascular outcomes. So Rob, welcome.
Thank you.
So I think as we think about healthcare redesign for the 21st century, we sort of got our roadmap early into the 2000s when the Institute of Medicine said that healthcare needed to be redesigned to focus on prevention. And so there was a call to action for the cardiovascular and the medical community to really move away a little bit from the focus on acute care to focus on prevention. And as we're thinking of prevention, we have to understand and look at cardiovascular care and cardiovascular outcomes holistically. And it brings us to what determines health. So as we think of healthcare redesign, we recognize we're dealing with the epidemic of chronic diseases. And so it calls for an expansion of how we deliver healthcare to move from acute care to really incorporate the components of prevention. And as you think about that, and we go back to that 2001 landmark document from the Institute of Medicine, they gave us the framework of 6 pillars that healthcare should be efficient, it should be effective, it should be timely, it should be safe. But 2 new pillars were added, that healthcare should be patient-centered and that it should be equitable. And those 2 pillars that were added, patient-centered, were really new to our entire sort of menu of how we deliver healthcare. And it has to do with the fact that we recognize that 80% of health outcomes depends on everything other than the medical encounter. And so a focus on empowering our patients to really change their lifestyles and be partners in the treatment plan is of importance. Secondly, that healthcare should be equitable because we recognize that disparities in health and healthcare delivery occur based on race, ethnicity, socioeconomic status. So this was a mandate from the Institute of Medicine. So you fast forward to where we are today, and we know that we are facing an epidemic of chronic disease, and it is not just a US problem. It's definitely a global problem. We know that 1 in 3 members of the world globally have one chronic disease. And we look at that, in terms of what are the chronic diseases: heart disease, stroke, dementia, diabetes, hypertension, kidney disease are all chronic diseases. And what they all have in common is that lifestyle and changes in how we live in the environment are critical for improving outcomes. You look at the United States statistics, and we see that at least 4 in 10 Americans have at least 2 chronic diseases. You translate that into the burden, the cost of chronic diseases, and we know that probably 90% of almost the $4.1 trillion that we spend in the United States on health is attributable to chronic diseases. And so truly a call to action to all of us in cardiology to really think of how we deliver care, but really have a holistic approach to healthcare delivery. And so it comes to the question, what are the determinants of health? So as we think about the fact that at least in the United States, about 133 million Americans are living with some chronic disease, and as we think of healthcare redesign, thinking of healthcare holistically, we come to the sort of understanding and the information from our population health gurus that in healthcare, we are only responsible for 20% of cardiovascular outcomes if we translate it to cardiovascular disease. And that the determinants of health are multifactorial, that where someone lives, their environment, their education, their jobs, all of these factors play an impact in what the outcomes are like. Additionally, the physical environment, important, as well as lifestyle behaviors. So in cardiovascular disease, we always customize a treatment plan where we tell patients that they have to
exercise and eat healthy and all those good stuff.
But if you live in an area where there's no area to exercise, you're not going to be able to comply. Knowing that lifestyle changes are a critical piece of our cardiovascular treatment plan for patients with coronary artery disease, patients with heart failure, patients with valvular disease, all of these diseases, and that lifestyle changes are critical, we have got to truly customize care to really know what matters to our patients, what are their determinants of health, of cardiovascular health, and incorporate that into the treatment plan.
I also think that we're at this inflection point where we have been trained in medicine to only concentrate on the biologic determinants of health. That 20% is what we've been told over and over is our job and our duty. And that 80% we weren't ever educated on. And I think there is a paradigm shift right now, which may create some tension, but it's an opportunity for learning. If we really want to take care of our patients in 100% of their health outcomes, we have to understand the social determinants. We have to understand the socioeconomic factors of physical environment, because we can't be siloed to only the biologic determinants of health, because then we won't be taking care of our patients totally and having total health under our umbrella. So I think this is of utmost importance, and it's why we haven't heard about this, I think, as physicians for some time, is because we were relegated to really concentrate on that 20%, and now we're looking outside of that.
And it's rather a daunting task, right?
Absolutely.
So I think hopefully at the end of our conversation today, everyone will feel that they can make one small contribution to really partnering with their patients to improve the cardiovascular outcomes. So as we think of, practical steps that we can take even at the bedside or with the cardiovascular team when we're fostering that partnership with our patient, I think we have to be cognizant of what are the determinants of health and where we can definitely have an impact. So you think of the broad spectrum of social determinants of health, you think of economic stability, right? Someone's income, their ability to buy medications, we have to factor that in. You think of we're giving them a treatment plan where we're saying exercise, as you mentioned, where do they live? Having a discussion of are they able to get, that 30 minutes that we recommend is important. So knowing the neighborhood and the environment, definitely important. Education is a critical piece because someone's ability to really understand their disease state, their health literacy, and really follow a treatment plan. And sometimes our plans are complicated, right? 2 or 3 pills, 3 times a day, 4 times a day, weigh yourself. That we have to sort of know their educational level. And really here is where we talk about the teach back, where you have to say, Mr. Jones, tell me, how are you going to explain to your loved ones what has happened? How are you going to take these medications? So health literacy is important. Another piece is knowing their preferred language. What language are they speaking at home? Because we live in an English-speaking country, and depending on where you are in the world, understanding whether someone spends 80 to 90% of their time speaking in their native language is important, because that's how they're thinking. So language access is important, and this highlights the importance of communication. Additionally, family support is important. Who is supporting them? Who is definitely able to help support them through their cardiovascular disease illness? And then the other piece that we sometimes forget or we take for granted is food insecurity. How many meals are they getting a day? In cardiovascular disease, we talk about a heart-healthy diet or heart-healthy options. Do they have access to healthy foods, or are they just eating processed foods? And then you think of the safety issue, right? Community safety is also a determinant of health. Are they in a safe environment? Do they have support? Again, all important. Now, as we focus on healthcare, what can we do at the bedside will be what we're going to discuss. And let us use a case to discuss that. Also, we have to recognize that social determinants of health drive health disparities. We also have to recognize that it's beyond just race and ethnicity, because your culture, your religion, your lifestyle choices all are part of determinants of health. And we, as part of the cardiovascular team, need to factor those into consideration when we're coming up with a shared decision treatment plan. So as we think of social determinants of health, and let's take it to the bedside, I think the best way to discuss this is by thinking of a case. So I want to discuss and get your thoughts on how we could have improved this encounter with a 49-year-old woman who was seen in our health system several years ago, who she is a native of Colombia, came to this country 20 years ago, works as a banker, and had a history where she was coming in with 6 months of intermittent chest pain, shortness of breath. The symptoms came on with emotional stress. She had gone to the ER a couple of times. They sent her home, thinking that it was probably GI upset. And what was interesting was that her history was significant for complications of pregnancy. So she had gestational diabetes when she had her first child, and then she had preeclampsia during her last pregnancy 8 years prior at age 41. Her father had had a CABG in his 50s. She had an older brother that had a stent placed. And yet, after all of those ER visits, because her symptoms were a little bit not fitting into the textbook of what we think of, heart disease or heart attack, she was sent home. So she suffered for 6 months, intermittent symptoms, and then finally came in the setting of a prolonged episode of chest pain, true chest pain this time. Her blood pressure was 158/90. Her hemoglobin A1C, just to look at the whole profile, was 8.5. Her LDL cholesterol was 140. And she went on to the cath lab and had a stent placed because she had a significant stenosis of her LAD with diffuse disease in the right and the circumflex. So here's a 49-year-old woman who had been ignored, finally got treatment. And so we sent her home with a long list of, therapies: aspirin, clopidogrel, statin, ACE, beta blocker, diabetic medication. She was placed on metformin, and she was told, importantly, you've got to exercise 150 minutes every day, and you've got to change your eating style or your diet to really make it fruits and vegetables. So just looking at this story, which is something we see every day. First, she was, misdiagnosed because she's a woman, and that's a whole different story. What are the chances of her sticking to that sort of prescription?
I think this is a really important case to highlight, and it's what happens after you've been ignored. And I think you're right. I think that's a different discussion about women being ignored for symptoms. But imagine if you're starting with no medications or very little medications, and then all of a sudden taking a lot of medications. We know that that is burdensome for our patients. And then exercising 150 minutes a week. When I was seeing outpatients, there were patients that I told, as a cardiology fellow, exercise. Go and exercise at least a brisk walk of like 30 minutes, exercise. And the patient said to me, where? I live in a pretty violent neighborhood. We don't have green space. Where am I supposed to exercise? And it really dawned on me that everything that we've been telling patients for decades, that we haven't really been thinking about them outside of our clinical encounter. We have no idea where they live, how they can exercise, and they come back with these problems, not because they weren't adherent to our recommendations. It's because we were naive to where they lived and weren't able to tailor the recommendations to someone's social or living environment or physical environment. And I remember that was one of the aha moments that it's really important to understand these things before we tell our patients how they should eat, how they should exercise for great cardiovascular health.
So do you think, what are the chances that when she comes back for her follow-up visit, that all is okay, that she's pain-free and sticking to the plan? If you were to bet on it, 10%, 20%, 90%, 80%?
I would say probably 50% or so that she would be adherent to this medication regimen. And I think there's things that we could do to improve that percentage, and I think we'll talk about those things. But again, it's such a big shift when you're starting these medications and making sure that the patient understands each one of those medications, why they're there, and which ones you can stop, which ones are the most important. How you prioritize that list is also really important.
And very often, because we have been so focused on the acute setting, you say, oh my goodness, I've placed the stent, I've saved her life. We forget, as you correctly said, to think about, is she going to be able to comply with this treatment strategy? Does she understand? You just had a life-altering event. What are we doing to say we're sharing decision and really driving home the fact what you need to do? So you guess 50%, and I will tell you that, probably not so much, because 3 months later, she comes back to the emergency room, and she had built a trusted relationship with the group of doctors that made her diagnosis, that didn't ignore her symptoms. So she comes back to the emergency room, and she has, a non-STEMI, and goes to the cath lab, and we find stent restenosis. What do you think happened?
Yeah, well, luckily it's not stent thrombosis, so she was probably taking some of her medications. But stent and restenosis, we wonder, has she been taking all of the medications that she's been prescribed? And does she understand her medication regimen and why it's important, et cetera? And so I think I would go back and ask about that, and ask, had she been taking her medications? Does she understand her medication regimen?
So I think you're 100% right. And it made us realize that after, we looked at, dealing with the stent and whatever, having a conversation with her, one of the team members, because she was pretty distraught about the whole thing, and going over her medication list, we recognized that she had taken her aspirin for the first 2 weeks. She stopped that. She was taking the clopidogrel. She didn't understand it was a blood thinner. She was not taking it as prescribed. So she actually was not compliant with her medications. And one of our nurses who was taking care of her also happened to be from Colombia. And, when she recognized that, they started talking in Spanish. And it was sort of an aha moment, because we recognized that she spent most of her time, including where she worked, thinking and speaking in Spanish. And she confessed that she was overwhelmed by the medications, didn't understand. And here was somebody where health literacy, as well as communications and language access, became a problem. And so, spot on, once we decided to use medical Spanish, we got an interpreter, but a lot of our team members were able to communicate fluently in Spanish. She understood what needed to be done.
Yeah, I think that's a really important point, that sometimes you converse with people and she's a banker, she's been in the country for a while. There's a presumption that she understands everything about her medical history and what's going on with her at that time. But sometimes medical information, even for some people who speak English, is not very clear, depending on their health literacy, how they understand things. And so it's important, I think, even regardless of language, that you check in with the patient and make sure that they understand the plan. I always call it a fire safety plan. So in case there's a fire, which medications are most important, which ones you shouldn't miss, and why those are important. And I think you have to make sure your patients understand. And if there's a language difference, if they're a native speaker is other than English, it's really important to go over and make sure that they understand it, and teach back, which is what you mentioned before, and can tell you their story, tell you the medications that they need, and why it's important.
So truly important in co-creating a treatment plan that's sustainable. And so as we think about that case, and we think of the entire array of strategies or of components that impede one's ability to stick to a cardiovascular treatment plan, there was a publication from several years ago, but I think it's still relevant today, that highlighted there are 3 areas that we have to consider. One, that patients, their whole sort of holistic environment has an impact in adherence to a treatment plan. And so this is where the social determinants of health come in. Their language, their religion, their culture, their pride, access to medication, their income. What are their beliefs about health and diseases? So we have to factor that in. And in this case, it was her language, that even though she understood English, that's not how she thought or, communicated for the most part. Then there are factors from us, the healthcare team, right? And this is where, how we communicate matters. Are we doing teach back? Are we making judgments? Or own unconscious bias comes into play, and something probably worthy of discussion, right? And are we using judgments based on our patients or what we think about them, or making a shortcut in terms of treatment strategies or how we explain it to them? And that we know there's a growing body of evidence to highlight the fact that our own unconscious biases have a role in health outcomes leading to health disparities. And then there are factors from the institution or the healthcare system, things such as wait times, building trust, really not giving our patients the access they need. Additionally, factors labeled as sort of the structure of institutional racism. Are we having our patients, because they're socioeconomically disadvantaged, come to our clinics where they have to wait, where they don't have access to different treatment strategies? So 3 areas, and I think that as we think of cardiovascular healthcare redesign to incorporate the determinants of health, and we think of the factors that affect a patient's ability to stick to a treatment plan, we have got to incorporate these determinants into our entire algorithm. We fast forward to our patient, and she comes back 6 months later, and we look at her statistics and we see her blood pressure is 120 over 80, hemoglobin A1C is now down to 6.2, and her LDL cholesterol is down to 70. We still have room to go, considering that she had a stent placed, but clearly she feels happier. We communicate in Spanish, and we go through all of her medications, and she's definitely changed her diet a little bit to have less processed foods, and she's getting some activity in. She likes to dance, so that's how she gets her heart rate up, and that's her idea of exercise. And it was really an aha moment for the entire team, because it shows the power of not only health literacy, but how you communicate with someone. And using the teach back method, we were able to get her on track, and she remained pain-free following her cardiovascular regimen.
I think it's also important to realize that medicine has evolved. If you think back to where medicine was, let's say, centuries ago, the doctors came from the community. You always see the doctor with the black bag going to the patient. And so the doctors, decades, centuries ago, they understood the social determinants of health for all of their patients because they were in the communities. And so as medicine has evolved and we take care of patients who are not in our particular communities, or we don't know these communities, I think it's important to reflect back on the time when those doctors knew who was doing well in school, what were the crises in terms of infectious diseases, who was having problems with their work, who was having problems with their lives. The doctors really were on the block. And as medicine has advanced, that's no longer the case. But I think that's why it was so successful back then. And we need to understand and learn from our history in order to deliver better healthcare, even though we've evolved.
So true. And you think of your own personal experience when you went to see your doctor. It was sort of a partnership. He or she knew things about you. You felt that trusted relationship that you could share information. And it was truly a partnership. And it brings us to, as we think of healthcare redesign, to improve cardiovascular outcomes, and in integrating the components of determinants of health, whether it's language, whether it's socioeconomic status, whether it's education or food insecurity, and factoring that in, we can't solve it all in cardiology or in medicine. We definitely have to evolve partnerships to take care of this. And so it brings us to thinking of our patients as part of the healthcare team, as part of the cardiovascular team. And this whole concept of the patient as a partner. So it's patient-centered partnership, I like to say, is how we need to think about it, because we know that quality healthcare can only be achieved with a partnership when we incorporate what matters to our patients, where they're coming from, to incorporate that into the shared decision of a treatment plan that becomes sustainable. So as we think of the impact of the social determinants of health, there was a publication in our circulation a few years ago that really showed the pathways of two identical patients. This was hypothetical cases. Two patients, both having coronary artery disease at the same time, but one patient A being highly educated, perceived by the healthcare system as being interested in his health, and you follow that patient along. He's engaged, he's part of the treatment plan, and he lives to be 77 or 78 years old. You look at patient B, exact same age, came into the ER with the same diagnosis on the same day, and he comes from a less socioeconomically achievable status where he works a couple of jobs, high school education, and perceived by the healthcare team as not really engaged or interested in his health. Shows up late for his appointment, misses an appointment, and you look at the trajectory, if left unchecked, and no one is customizing care, and he's deemed not adherent with the treatment plan or non-compliant, as we used to say. And you can see what the impact translates to, a 4-year difference in life expectancy. And we're seeing that play out in today's world, right? So as you look at this hypothetical case, which we see play out in daily lives, not including social determinants can definitely have an impact on someone's life expectancy as well as quality of life.
Absolutely. It seems like it will definitely affect mortality and quality of life and all of these hard endpoints that you have.
So given the evolving evidence on social determinants of health and their link to outcomes, the American College of Cardiology, the American Heart Association in the 2019 prevention guidelines actually included a roadmap and highlighted the evidence and the importance of social determinants of health into the cardiovascular treatment plan. And so from our guiding bodies, we now have evidence that speaking to a patient about their preferred language, access to food, health literacy should be part of the cardiovascular treatment plan. And so you see it in the guidelines. So as we look at the guidelines, there's definitely a roadmap as to how we can incorporate the social determinants of health into our daily practice of cardiology, into our treatment plans. And it involves incorporating the components of health literacy, so doing teach back, understanding our patients' social and cultural beliefs as it relates to health, their neighborhood environment, their psychosocial stressors, and whatever barriers there may be to sticking to a cardiovascular treatment plan. And so we recognize that even at the bedside, thinking that your patient is a partner, and in any partnership, knowing what matters to you, what matters to them is important. So definitely discussing, sharing the decision making, find out what matters, doing teach back, definitely of vital importance. And the teach back, I think, is instrumental because it really gives you insight as to whether they understand about the disease, what they need to do for prevention. So I think, in conclusion, social determinants of health, important for improving cardiovascular outcome, and can have a profound effect, if not incorporated, on a patient's life expectancy as well as their quality of life. And for further information, see the ACC-AHA 2019 Prevention Guidelines.